2021 budget. And we got some different protocols, as most of us are used to this year. With COVID, we have members that are remotely. We have presentations that are going to be done remotely. And so as we go down through the list and as we take roll, if you can announce yourself, if you are in the room, in your Frankfurt office, or at home in your district, so that staff will be able to record you right for your per diem. At this time, can we have the secretary call the roll?
Senator Rocky Adams, Senator Carroll, Senator McGarvey.
I'm here remotely in the district.
Thank you, sir. Senator Meredith,
Present in the room.
Representative Bowling,
Present in the room.
Representative Gibbons-Prunty,
Present in the room.
Representative Raymond, Representative Sheldon.
Here in the district.
Thank you. Representative Stevenson.
I am here in my annex office.
Thank you. Representative Weber,
Present in the room.
Representative Westrom, Representative Wilner.
I'm here in the 35th District.
Thank you. Senator Humphreys, Senator McDaniel, Representative Moser, Representative Reed, Representative Rudy, Co-Chair Bentley,
Here, present in the room.
Chair Castle.
We do have a quorum, and so I would ask for approval of the September 16th meeting minutes. We have a motion. Second. Well, thank you all for that, and it's a beautiful November morning. Not many days until we have 70 degrees on early morning like this, and so we are going to be having a quick committee meeting today. We're going to be limited to about 45 minutes altogether due to the room has to be cleaned for the next committee meeting here shortly after lunch. So at this time, I'm going to ask Secretary Freelander. Okay, all right, Secretary Freelander and Eric Riley will both be presenting remotely, and I would ask you to announce yourself for the record, and the floor is yours. Yeah, the reason they couldn't hear me is I forgot to have the microphone on. So we're going to start over here. So we have a limited committee meeting at this time to 45 minutes due to time constraints for the next meeting that's going to be in this room. And so today, Secretary Freelander and Eric Lowry both will be presenting to the committee for the 2021-22 budget and what it's going to look like. And they're going to be presenting to us remotely. If you can announce yourself for the record, the floor is yours. Secretary Freelander, can you hear us? Maybe show us a thumbs up because we can't hear you. Okay, the presentation is now on. Check your mic and see if it happens to be muted. Thank you. Members, just be patient 1 second. We're going to see if we can fix this technical difficulty here in the new world of virtual meetings. As we're trying to figure out the technical difficulty, and Secretary Eric Lally and, I'm sorry, Secretary Freelander and Eric Lally, if you all can hear me, we're gonna hold tight on your presentation, and we're gonna let the second presenters come forward because they're in the room as we try to figure out what's going on. So at this time, if Mr. Gary Rutherford and Mr. Chris Carlson with Health Plan Data Solutions can come forward here at the table, put the microphone between you all, and if you will announce yourself for the record, we're gonna give you 15 minutes for your presentation. Thank you.
Maybe we remove our masks? Thank you. My name is Christopher Carlson. I am Senior Vice President of Government Affairs and Compliance for Health Plan Data Solutions.
And I'm Gary Rutherford, co-founder and Chief Clinical Officer for HDS.
I'm going to have Gary introduce our company and just give you the kind of framework of our company. Generally what we do, I'll go through a very brief presentation and then be happy to answer your questions.
Okay, well, thank you for having us. Appreciate it. So we started Health Plan Data Solutions 11 years ago. I'm a pharmacist. I have a very broad background in pharmacy, and I've worked in hospital pharmacy originally. Then I was in a chain pharmacy. In fact, we had stores here in Kentucky with Drug Emporium. It was actually an independent company that we grew significantly. But I've owned a pharmacy and operated it, and was looking for a way to take what I knew as a pharmacist to look at data and look at it in a way that I think one of the biggest problems with healthcare in general is that we don't really understand what's going on because there haven't been methods to really bring the data all together. And we don't have accountability in healthcare. Everything operates very, very independently. And I wanted to write a piece of software that had the brain of a pharmacist in it that could evaluate drug utilization, pricing, market competitiveness, legal issues. I mean, everything that is concerned with the utilization of medications as part of the healthcare system. And I wanted to do it for populations so that I could help more than just one patient at a time, as I had done as a pharmacist for years. And so we put together a team of pharmacists and IT professionals to start trying to put this brain into a piece of software. And it's gone through several iterations over the years, but we've developed a piece of software that can look at every aspect of a prescription benefit plan, whether it be in the public sector, commercial sector, in a managed care organization, wherever it occurs. And we basically can provide the payer with all the information they need to make good decisions. We're not making the decisions for them. We just give you the platform where you can make the best decision for the healthcare plan. And so, we like to say that healthcare and looking at the issues that we've had with PBMs is much like managing children. In that you need accountability. If you don't have accountability, all kinds of things can happen. And naturally in the world, things just kind of go to disorder without oversight and accountability. And so we give you the tools that you need to have insight into every aspect of your plan's performance.
And so if you really wanted to boil it down to the couple of things we really want to leave with you today, those are, that complexity, such as it is in any scenario, leads to errors. There are a lot of errors that are naturally generated by extraordinarily complex systems, whatever they are. And I think that's probably natural to everybody to understand that. Well, your pharmacy benefit programs and systems are extraordinarily complex situations with all the moving pieces and parts, millions of claims, hundreds of data elements on every single claim. And this comes to a payer, and they're only given days to evaluate these thousands or millions of claims, these hundreds of data elements, to determine whether or not it's appropriate to pay that claim. And what happens in today's, across the nation, this is not a Kentucky-specific problem, but is a problem Kentucky is showing significant leadership about with Senate Bill 50 and the efforts that you all have undertaken to better understand and to better control PBM activities within the pharmacy program. But those, that level of complexity leads right now to a system where you pay out without real knowledge about whether you should or how much you should pay on each of these claims. You wait to the end of a plan year, you audit it, and then you wait months, if not over a year, to try to figure out, hey, how did everything work that last year, 2 years ago, or whatever it may be in that pharmacy or in that audit cycle. So this extraordinary complexity in the current system leads payers across the country to not always paying for only what they should pay for. And that's the other theme here. We provide a platform, HCS provides a platform that we call Pharmacy Payment Integrity that allows you as the payer, the state of Kentucky, or its MCOs, state of Kentucky and its fee-for-service, or any commercial payer, to know that they receive a bill from a PBM, it has a claims file associated with it, and this software platform and our team, our bench of pharmacists, can do a complete analysis of every one of those claims. After they've already been adjudicated, the drugs have already been dispensed, the pharmacy already knows what is going to be paid. We do a complete re-adjudication of all of those claims and then tell you, the payer, which of those claims should be paid and are perfectly legit according to your contract, regulatory compliance, plan design, all different factors. 80 different scans we're running, more than 80 different scans on every single claim. And then tell you which ones should you not pay. Where were the mistakes that were made in this very complex system? And only pay out what Kentucky should pay out to these PBMs. And so this 100% adjudication or 100% analysis after the adjudication process at the pharmacy, but prior to payment, is really the magic ingredient here for HDS. It is this combination of technology and pharmacy that allows this to happen, and it doesn't happen in any other scenario across the country. We know of no one else who is doing 100% claims review in the 5-day time frame that your agency has from receipt of a bill to paying for that claim.
May I insert something here?
Was that?
May I insert something here?
Oh, yeah, absolutely.
In my experience with, when I was running the pharmacy department for Drug Emporium, PBMs were a godsend for me because I went from having paper claims piled up in a shoebox in the pharmacies and months old to them adjudicating it electronically. And the reason they could do and grow and provide the service that they provide is they had access to technology that most of us didn't have. Today it's available, and so there's more options than just 1 or 2 PBMs. But we have the ability at HDS to process over 1 million claims in 20 minutes. Totally tell you everything that you need to know about those claims in 20 minutes. So we have the capacity really to run the billing cycle in a very short period of time. And accountability in near real time changes behavior. And we've seen that over and over in the industry. And as we're able to tell the payer, you know, something's not right here, the dynamics have changed. So all the leverage had been with the PBM. They had a contract with pharma. They had a contract with your pharmacy providers. They had a contract with you. And they kept all of them separate, and none of us really knew what was going on. But now we can have accountability in near real time, and the dynamics change. Instead of chasing the correction of errors, you can confront them with the errors before you pay the bill. And funny thing happens is you go from dealing with lawyers to dealing with account management, and account managers want to make you happy. That's their job. They want to keep the account. And so it really changes the relationship. And I can say that we actually have good relationships with PBMs once they get in line with the program. And behavior changes. Payers are happier. Pharmacists are happier. The pharmacists in Ohio, their payments have gone up over 5% since they got rid of spread pricing and started looking at some of the pricing problems. Same thing will happen here. So.
And probably to close and get to your questions, because I know we're very short on time. We have been very interested in what you all have done down here in Kentucky and the interest you have shown in this issue. You are showing true leadership nationally with Senate Bill 50, with your new single PBM RFP that's on the street, with the work of the cabinet that's trying to get on top of this issue. Your biggest challenge is to try to legislate every single error that happens in a very complex system is not practical. So you've started something really strong here, and what we believe is with a system that can identify problems, fix problems, and then monitor problems on an ongoing basis near real time is the complement to what you have already started with Senate Bill 50, is the complement to everyone's interest in getting on top of the Medicaid pharmacy spend here in the Commonwealth. And so with that, we're happy to answer any questions you may have.
Gary and Chris, I appreciate your presentation. I know there's going to be some interest here. We always say when the cat's out of the barn, the mice will play. And so, you know, when you all asked to present, I did a little research on your company and your goal in mind. And I think there's several senators in the cabinet and other ones that would really have some great interest in seeing that we get the most out of our PBMs and that we hold them accountable. Does any members and any of those that are even remotely, if you can go through the chat box, does anybody have any questions? Representative Bolin?
Thank you, Chairman Castleton. Few questions, really short, but just to kind of get to the point. What other states do you all represent? Do you currently represent other states in their Medicaid, as payers?
Let's see. I mean, currently, right now, as you know, we work with the state of Ohio. We're actively engaged in contracting in Texas, in Georgia, in Delaware, and then multiple states. There's been we provide analytics for some people that are looking closely, some legal entities that are looking at PBM behavior in over 20 states. But we're not actually contracted with the states themselves.
Okay.
Yeah.
What type of savings have those states seen, like Ohio, who I guess you represent as a payer?
Yeah. I think a better way to answer this is really, what do our customers in general save? Because, one of the things the industry has done is they separate and say, well, you're the state segment, you're the workers' comp segment, you're the federal segment, and they've made the industry believe that the pricing was unique to that segment of business. Truthfully, the adjudication of claims and the management is very, very similar across the different market segments. And like in the federal space, we work with some federal employee health plans. We've saved them over 20%. And in our customers, that is typical. Now, coming into a state where you're going to eliminate spread pricing, and you have this House Bill 50, that's Senate Bill rather, 50, that is, I think, going to have a big impact. I would say that probably the estimate is probably going to be between 5 and 10% because of the steps you've taken, but it's going to be in that area.
Okay.
Yeah.
So, all right. Okay, well, thank you for those responses. We've got 3 more individuals that would like to ask a question. At this time, Representative Co-Chair Bentley.
Thank you, Mr. Chairman. Thank you, gentlemen, for presenting. The spread, we've all known about that, and the delay in payments, we've known about that. So I have about 3 different types of questions at different levels. First one is, when you get done with that claim, it's all clean all the way across, right? It's a clean claim.
It's claimed to be, yeah, I mean, it's past the adjudication process,
Okay, on the other side.
right?
Okay, so the benefit would be to not only the pharmacist and the taxpayer, but also it would give us a way of developing policy where there wasn't any misuse of taxpayer money and save money also, right?
Yes.
Okay, so my question is, why is the difference between doing this and a real audit by Medicaid first? What would be the difference and what could you say would be the savings? The way they do it now and the way you would do it?
Okay. We started really in the audit business, and it's retrospective. It can't be run until at least 6 months after the end of the plan year. And then you're arguing over what's already happened and what's been paid. And the PBMs have rooms full of lawyers that are very adept at arguing over what the definition of is. And so it was a very difficult situation. We'd find $3, $4, $5 million and then settle for $600,000 because everybody gets worn out. There's a real phenomenon of just audit fatigue associated with retrospective audits. So when you change it to the front end, you're making them, you're identifying problems, making the mistakes right, and preventing them going forward. So you're still probably, as a state, going to want to do a retrospective audit. You're probably required to do a retrospective audit, but you're going to be looking at a few claims instead of a huge bucket of claims. And so, it's better utilization of your resources. You're not putting a whole team on an audit. You only need a few people, really.
Okay, thank you. And my second question is, in addition to incorporating this into a new single PBM for the managed care pharmacy, what about also using it for pharmacy under Medicaid fee-for-service? How would we have an advantage there? That'd still be a portion of Medicaid for us.
Right. Well, you know, the same problems occur with fee-for-service, and we've looked at that, for instance, in Ohio. The PBMs in that space are transparent, but transparent doesn't mean mistake-free. And so the same dynamics happen. You find errors as they occur, like miscategorization of a drug, mispricing of a drug, don't have the pricing updated to be market competitive, et cetera. So you're just helping them run their business more efficiently and fixing things in near real time.
Okay. Thank you, Mr. Rutherford. Thank you, Mr. Chairman.
Okay, we got just a couple minutes here. We got two more questions. Representative Sheldon at this time.
Yes, Chairman, thank you very much. Thank you guys for presenting. I think accountability in government is everything, and I think this would be good for Kentucky policymakers. It'd be great for the cabinet, I think, to have somebody go through actual live claims and to be able to keep their hand on things as we go. So I guess a couple questions. As health data, there's a lot of moving parts, as you explained, but in your analysis, do you take into account all rebates, including supplemental rebates?
Yeah, I mean, now rebates obviously are not evaluated in real time, but we're calculating what rebates are due to the payer by claim in any period of time you want to look at it. Usually it's quarterly.
So you are able to actually produce a report that you could give to our cabinet that says, this is what you should be getting in rebate?
Yes, sir. Yep.
That's remarkable. That alone would be good. How do you all get paid?
Generally, it's on a per member per month basis, and it's based on the size of the group. Sometimes we do a combination of, we guarantee return on investment, and then anything over that investment, we might have shared savings. It depends on the state and the entity whether or not they can do shared savings.
It would seem good for us, I would think, that we could, if everybody, if people wanted to consider it, and certainly we'd want to talk to the cabinet, but I think they would be very interested in this, but it would seem to be anything that you all could save, if it's 5 or 10%, percentage of that would be, we would have nothing to lose in this situation if that were the case. That's why I asked.
Mm-hmm, yes.
Yes, sir.
Oh, thank you very much.
Thank you, Representative Sheldon. So this will be the last question, but Chris and Gary, I would ask you all to stick around after this, because I think there's a few other members that might have some questions, but we're going to have to get to the next presentation, and they might be able to speak to you in the back of the room. So at this time, Senator Meredith with the last question on this subject.
Thank you, Mr. Chair. And it goes back to this discussion about your revenue stream. So you mentioned a lot of customers, but your ultimate customer in this scenario for us would be the Department of Medicaid. Is that correct?
Yes, sir.
So you would have to negotiate that contract with them as far as the specifics per member per month. So we're assuming that we're not increasing the overall cost of administration because those fees should come from the PBM and the MCO. Is that fair? If you're doing a per member per month, because you're reducing their costs, so their monthly payment should be less.
Are you saying the savings would pay for the cost of
Yes.
the? Yeah, we're guaranteeing a return on your investment, yes,
All right.
yeah.
Again, Mr. Chairman, I appreciate this presentation, and it really maybe, I know we're getting late in the year, but I think it warrants further discussion and review. It's quite fascinating. I appreciate the presentation this morning. Thank you.
Thank you.
Well, gentlemen, thank you all, and you can tell that there's some interest here. Being the Budget Review Subcommittee on Human Resources, it's our job to be stewards of the taxpayers' money, and I think you're going to see several members have some interest in what you're all talking about. But thank you all for your presentation, and there'll be some members probably hit you up at the end of the meeting for more conversation. But at
Thank you
this
for
time,
having us, appreciate it, thank you.
we're going to try it again here virtually with Secretary Freelander and Budget Director Eric Lowry. If we can turn it over to them, you announce yourself for the meeting. The floor is yours.
Can you call in?
Yes, can you hear me?
Yes, we have you now. Thank you.
Oh, good. Sorry about the technical difficulties. We were trying to connect on the other computer, and we were able to see and hear, but for whatever reason, the microphone was not working. Here we go. Secretary is here.
Do we have our presentation up?
Let's see. We have video on presentation. No, I do not see the presentation.
Some of us members have.
Okay, Julie, why don't you do it from there?
Okay.
Okay, so you share the screen from there, sorry. High tech, guys, sorry about that.
And
So
the
I'll
members have
start.
been sent this information in advance, and we have a copy at our table, so you all can go ahead and start if you want to.
Great, thank you. I'm Eric Freelander, Secretary of the Cabinet for Health and Family Services.
And I'm Eric Lowry, the Budget Director for the Cabinet.
So I'm going to turn this over to Eric the other Eric, pretty quickly. Wanting to let you all know that we have gone through closeout. We're looking at the current year budget. We think it's good news. We closed out well. You'll see in our different departments where some of the federal funds have come in, and we believe we will be on budget in the current year. So I think all of that's good news. And I'm going to turn it over to Eric Lowry to give you the full presentation, and we'll take questions afterwards. Thank you, and I do apologize for the technical issues.
Yes, thank you. Next slide, please. There we go. I would start by saying that the 22 budget has not been developed yet. Budget Director Hicks is going to testify to the full A&R committee later today. So I would apologize for not having numbers for 22, but what I have provided is a 3-year snapshot showing the prior 2 years of history, the actual data for those years, and what our current budget is now. This slide depicts our cabinet's budget broken out by fund source. As you can see, we have had a significant increase in overall expenditures over the last 3 years, and a large majority of these expenditures are related to responding to the coronavirus pandemic. From 2019 to 2021, there was a $3.5 billion increase in total expenditures, of which the majority of that is federal funds. Next slide, please. Next slide, please. There we go. As you can see, the percentages of the cabinet, 73% of the cabinet is made up of federal funding, 18% is general, and 9% is restricted with a small portion of tobacco. This is pretty consistent with previous years. We did not see any significant changes there, no major shifts.
And the majority then here for the general fund is tied to a federal dollar in some way. Vast majority of our general fund is tied to federal.
Yes, last fiscal year, 87% of our general fund dollars was tied to a federal dollar in some form or form. The next slide, please. This slide depicts the same information. It has the cabinet listed by each individual department within the cabinet. I won't go through every department today in the interest of time. I would just point out for a lot of them, funding has been fairly flattened over the years, but the ones that we have significant increases are typically related to response to the coronavirus pandemic. The federal government passed 4 funding bills, and a lot of the funding that they passed are reflected in these departments, such as aging and independent living receive money for meals, caregiver services, and supportive services. The Department for Public Health received money that has been provided to local health departments for assistance, for testing, and for contact tracing. Behavioral health received some provider relief funds. Community-based services received a lot of funding for LIHEAP, for utility assistance, child care centers, various things like that. Obviously, Medicaid received the largest amount of increased funding. Of course, the FMAP was increased by 6.2%. We have that FMAP increase until at least the end of March. So we feel quite confident that we're going to balance this year with our expenditures. And that increase in FMAP will help us mitigate the increase that we're seeing in enrollment. We've had 272,000 individuals enroll in Medicaid since March. So the FMAP has allowed us to stretch our dollars much further.
And that was the design of the FMAP.
Yes.
The FMAP put us in such a way that we couldn't change any rules about reducing our roles. That was something that we had agreed to get the increased FMAP, and it's significant for the cabinet for the state.
This slide shows the breakout of our funding. Medicaid typically runs about 80 to 82% of our total cabinet expenditures. DCBS represents 9%, and then all other departments make up 9%. That all other departments covers behavioral health, covers public health, aging. It covers quite a few different things in that tiny sliver of the overall portion. The last slide I would go over with you shows our breakout of expenditures and how we spend our dollars. 93% of the dollars that flow through this cabinet are sent out in grants, loans, and benefits. We have a 7% overhead, which is something we're quite proud of. We try to maximize the dollars as much as we can and serve as many people as we can. So any chance we have to drive down our overhead costs and put more money to the public is certainly something we're always looking forward to doing. So in the interest of time, I will end here. And thank you for allowing us to testify for you today, and would open it up for any questions you may have for us.
Yeah, and thank you for letting us run back and forth between rooms. Thank you, Julie, for listening to us on the, we can take the video back.
Secretary,
Uh,
Secretary
yes.
Freelander and Budget
Yes.
Director Eric, appreciate your presentation. I'd say when we're dealing with $16 billion, there's going to be some questions that come out of this room. And I'm going to start with the first question here, going back to page 2 of your presentation. With the 2021 budget increase, we're seeing about a $53 million increase to the general fund request, and then we're seeing about a $500 million increase in the restricted funds. Can you touch on what that is and where that's coming from?
Sure, and Eric, you correct me when the bulk of the general fund increase has to do with increase in retirement health and basically what is considered to be defined calculations relative to our personnel. And then the restricted fund increases have to do with primarily with how Medicaid flows through the cabinet. It's earned by different departments and comes in as restricted funds. So some of that is probably the vast majority of that. The only other piece of restricted funds would be fees that we have in local health departments or fees that we charge the general public. That would be the other agency fund, but that's not what drives the increase. The increase is driven primarily through the addition of Medicaid as it runs through the entire cabinet. Is that a fair way to put it, Eric?
It is, and there was the university piece also.
Yes.
With Medicaid, there was some changes to how intensive operating agreements were being done. The universities were putting up a portion of the cash, putting up state match in Medicaid, especially for the teaching hospitals and the university directed payments. So that made up the largest part of the increase in restricted funds.
And I think that's a good point. All of the Medicaid benefits goes to some sort of healthcare provider, hospital, nursing facility, physicians, all of the folks that we hear from around Medicaid, pharmacists. So that all of those benefits go there.
Okay, thank you all. And, a lot of us members here, we deal with this on a daily basis like you all do, and we talk about this. But for those who are watching at home on KET and the ordinary citizen across the Commonwealth, describe of that $500 million, how much of that is federal and how much is that going to be on the backs of the Kentucky taxpayer?
The $500 million is restricted. That would be all receipts from the universities, state match from the universities. It provides for the match in Medicaid.
Right.
But that's all restricted receipts.
Right. There's very little of that restricted fund that would come in the way of fees. Very little. We can give you a percentage of that, but I don't have it off the top of my head. I'm sorry, but it's a small amount.
Okay, well, thank you. And I was just trying to kind of simplify it sometimes for the people that are listening in. At this time, Senator Meredith has a question.
Thank you, Mr. Chair. And I'd like to start with your slide on page 4, obviously talking about the Medicaid program itself. Substantial increase for 21, which we anticipate because of the expansion Medicaid program. But can you give me the numbers for each of those columns of what the Medicaid benefits would be net of the federal match?
Net of the federal match.
Because this number is inclusive of the federal dollars, correct?
Yes.
Yes.
So I'm trying to.
You mean one of the state funds involved in Medicaid?
I'm trying to understand what portion belongs to the state.
I don't have that information in front of me, but the match rate typically, by the time you mix expansion and mix K-chip, roughly 75% of that is federal dollars and the remaining 25%
But
is
we're going
state dollars.
we're going to see a shifting of that in the future, right? As we see less federal reimbursement for ACA than we've seen previously. I mean, that's the way the program was designed. Is that correct?
No, we've already seen a reduction on the expansion side. Where we will see a reduction in the match rate with the additional 6.2s that was put on basically because of COVID and the emergency, that is scheduled to go away right now in March.
Yes.
So that's the only piece of the match that will go away. And that's on regular Medicaid.
Last question I have, Mr.
Expansions?
Chair, is on your slide on page 6. You're talking about 7% for administrative cost. That's not inclusive of the MCO fees, though, is it?
That would be reflected.
No, the MCO fees are reflected in the overall benefits side. So what that entails is basically all the personnel at the cabinet. So DCBS, behavioral health, public health, all of those folks who are through the cabinet.
So the actual administrative fee for the Medicaid program is really more like 17% than 7%. Is that correct?
You'd have to blend the rate. I think it's less than that, but you're correct. You would have to look at the MCO and try to the 90% MLR that they need to meet. So that portion, yes, I believe but you have to blend the rate.
Well, that's how my rate comes up, as we know with the 90% MLR that the MCOs are taking 10% plus your 7%. So I'm suggesting it's really a 17% administrative fee for the total program, not 7%.
Again, I think you need to blend it, but it certainly I understand what you're saying. Yes.
Okay, thank you. Thank you, Mr. Chair.
Senator, thank you. Secretary, thank you. So Representative Wilner at this time.
Thank you very much. And the 7%, I have a question about that as well. I mean, I think we like seeing those really low overhead fees as you know, the group that oversees these state dollars. Given the tremendous number of Kentuckians served by programs under CHFS, I'm wondering if you guys have adequate funding for staffing, if there's adequate staffing to oversee the tremendous number of programs.
Well, that 7% includes DCBS, so that also includes the social workers for the cabinet. So I would say looking at caseloads and other things like that, you can always look at the need for social workers, the need to support social workers. It's also then everybody in public health, which normally doesn't get the attention that we've been giving it right now. So all of that, all of that goes into that 7%. So it's to say overhead, I think is probably an oversimplification of what that represents. It really represents the personnel costs of the cabinet.
Thank you.
Does anybody else have any questions? It's the last budget review of the year. Well, Secretary and Director, Budget Director, thank you all for your presentation. Oh, we do. Representative Prunty has a question.
Thank you, Mr. Chair. With regard to Medicaid services, did y'all say the FMAP expires in March? Is that what you said, or did I hear that wrong?
That additional 6.2 expire
Okay.
is scheduled to expire in March. Yes.
Okay, how much savings has Medicaid realized through that program?
Gosh.
That's, it's been a little over $40 million a month in FMAP savings. Through yesterday, it is roughly $454 million since the start of the pandemic.
Okay, thank you. Thank you, Mr. Chair.
Representative Mosier at this time has a question.
Thank you, Mr. Chair. Thank you for your presentation. And can you all hear me?
Yes.
Okay. I got a little pop-up that said my microphone had been muted. I know that we've had these conversations numerous times, and it is a very complex system, and I really appreciate all of your work. Representative Prunty really touched on my question and in terms of the savings, but we still don't have, or maybe we do and we just didn't hear, in terms of what the state's expectation is. And knowing what kind of a budget that we're coming into this session, I think it's really important that we continue to find efficiencies in the services that we're providing. And I know that we've had some conversations about that. And looking at the real cost of some of the programs that we have. And so again, I appreciate your work on this, but do you have any thoughts about how we can find efficiencies? Do you have any plans for helping individuals transition back to their employer-sponsored insurance? Or, I know that we now have Connect relaunched, and so maybe that's, I don't want to put words in your mouth, but, how are we going to help folks transition off of the state benefits? Because we know that at some point we need to become more budget neutral than is being represented on your slides today.
There are several pieces. First, I want to say I want to thank the General Assembly for working through Senate Bill 50. I'm hopeful that that will be at least a way that we can make sure that our independent pharmacists are taken care of while we take care of the Medicaid program. I think we've had those discussions even as the bill was going through. We're the only, as the previous presenter said, we're the only state in the country trying to do it this way. I'm actually a little excited about it. I really appreciate the great work I think we were able to do together, and of course we're still implementing, but I do want to say that, and I want to say thank you. The second is, yes, we always have to be working towards getting folks to the point where they can work and make sure that they can get living wage jobs so that they can afford health care on their own. That is the goal I think we should all have. We are looking at the cabinet of how we help people reach their full human potential, and that is making sure that they are doing something that hopefully that pays them well enough that they can afford health insurance, and I think that's something we all want to see. And thirdly, yes, thank you for mentioning Connect, but I think really that just helps you get to resources, right? Not only state resources, but there's a whole piece of it that gets you to our resources across the state, which we've been trying to do for such a long time. And I think that being able to get that, being able to provide support, not just state support, but community support for individuals to be able to work through that. And as we bring more programs in, which is what I hope we do, even within the cabinet, we need to bring in WIC and some other programs into that portal. I think we're going to see, I hope, let's say it that way, I hope we'll see an easier and more direct pathway to getting to self-sufficiency. I'm hoping to even talk about how we maybe even support some small entrepreneurial activity. We did that a little bit at Community Services in Louisville, and I'd love to see us do a little more of that here. It's a path that I think is going to take time for us all to walk through together, but I think it's one that I hope we can all agree on.
Well, Secretary,
Thank you.
we got 2 more questions. They're coming now. So Representative Meredith, or I'm sorry, Senator Meredith has a question.
Thank you, Mr. Chair. And it goes with the delivery of health care. Obviously, as we're broadening the number of Medicaid recipients we have, it's not very meaningful if they don't have access to health care because the services aren't there. And Secretary, as you well know, we've talked repeatedly about the number of rural hospitals that are suffering financially. Before COVID, we identified, I think, 14 hospitals that were on the verge of possibly closure because of financial position. And today, that number has doubled, 28%. So you all have any special conversations or considerations about what we might do for those rural healthcare providers who have been impacted so adversely by COVID-19?
So there are additional funds available through the federal government, but the conversations that we've been having, in part with the Kentucky Hospital Association, I want to thank them. They have been, Nancy Galvani and the staff of the Kentucky Hospital Association have been fantastic to work with. I cannot say enough nice things about them. Their collaboration with Dr. Stack, their collaboration with Inspector General Mather, their collaboration with the cabinet and I in general. I can't say enough about that. We have worked on ways to make sure that we maximize within the Medicaid program reimbursement to hospitals. We're working on a state plan amendment to make sure that we provide as much support to the hospitals as we can. Within that discussion, we wanted to make sure that whatever we did not negatively impact rural hospitals. And so we're going to keep a very close eye on how we are implementing the state plan amendment, how we divide the disproportionate share pool to make sure that we are supporting our rural hospitals as strongly as we can. The General Assembly passed something that I think is a great. I think you've had this conversation. Some kind of infrastructure pool for rural hospitals. That's where I've seen when there's deferred maintenance, when there's deferred that infrastructure support. That's when I think also some of the rural hospitals get behind. And when you get behind on that deferred maintenance, it is hard to catch up on the hospital side. So I think there are things that we can continue to work together on that I really do believe will make a difference.
I appreciate your shout out about that piece of legislation that was Representative Bentley's. He did do a great job with that. My only concern was that's an unfunded mandate. We didn't allocate any funds for that. I'm assuming we'll do that in the next budget, I hope. So to that end, or have you all given any thought or even calculation as to what kind of assistance we may have to provide under that fund? Because it needs an allocation to be successful.
Correct. I actually think we might be able to work with our existing providers. Like the hospital association. I think maybe even with some of the MCOs, believe it or not, I think there may be some fruitful conversations there.
Thanks, sir. Appreciate it. Thank you, Mr. Chair.
Last question for 2020 Budget Review Committee, Representative Prunty.
Thank you, Mr. Chair, for your indulgence. My second question. Secretary Freelander, you mentioned Senate Bill 50 and working with getting that implemented. I have several independent pharmacists that contact me continually in my district. So are you saying that that's going to be implemented on January 1? Has that been moved up?
What we hope to have in place is the contract in place January 1, and then as soon as we can afterwards. The latest date is July 1 to get Senate Bill 50 implemented. In between that time, we have made sure that the MCOs know that they are subject to the provisions of Senate Bill 50, and we expect them to adhere to that. And we have made that very clear as we have talked with them.
Well, my independent pharmacists keep asking me why it can't be January 1, so just please keep that in mind as you move forward. Thank you, Mr. Chair.
Well, Secretary Freelander, Budget Director Eric Lowry, thank you all for your presentation. We know as a committee we look forward to working with you all during this short budget year, an unusual time, but we're going to work through this for the people of Kentucky. And members, thank you all for your indulgence during this meeting, and look forward to 2021 being here and the session kicking off. So thank you all and have a great day. Meeting is adjourned. Do I have a motion? We have a motion and a second. Thank you.